the graft soon. But now I'm showing you the inside part of this knee. Okay, I'm going to trim the meniscus because that's the initial preparation. You need to trim the meniscus and leave around 1 or 2 peripheral margin of the meniscus intact. That is a mandatory for most of the meniscus transplant because that rim will prevent the subluxation or meniscus extrusion over a period of time. So keeping 1 or 2 mm medial meniscus rim is very important. So I'm going to taking off this most of the native meniscus now to demonstrate the allograft transplant. So I'm just going to clean it up first. Then probably I'll be starting with the procedure soon. So since there is already multiple procedures that has been done on this cadaver, like already medial meniscus root repair has been done, PCL has been done. So I just hope I don't get to have a difficulty in preparing the root and roots for both the medial and for the posterior and the anterior roots. So I'm going to clean up all these things. Okay. Okay, yeah. Clean up the shaver blade, please, and give me a meniscus punch. And it's very important to do a MCL pie crusting to get the space opened up. Because medial meniscus transplant, you need a good space to perform this procedure. You can't be struggling with passing the instrument. So you need to open up the space thoroughly so that your graft goes inside and you don't end up struggling with this. Okay, so I'm going to shift my scope so that I can pass my meniscus punch from the other portal and remove that middle third and the anterior part of the native meniscus intact. Meniscus punch, please. Okay. So meanwhile, if you have any questions, you can clean it up.
Hi, Raghu.
Oh, hello, sir. Good evening. Sir, it's a
Good
wonderful
evening.
talk.
Good evening. Thank you so much.
It was very elaborative and
Everybody,
detailed.
yes. Now, if you are looking at this young knee that you are doing a meniscal transplant,
Yes, sir.
correct?
Yes.
So, in your hands,
Assuming so, yeah.
you have traveled that path ahead of all of us.
Yes.
What would be your ideal conditions and ideal intra-op decision makings when you look at the knee and say that this is the knee I will transplant or this is the knee I will do something else?
So ideally, the patient should be between the age group of 20 to 45 to 50. That's the ideal age group. And they should have undergone a subtotal or a total meniscectomy in the past. And they should be having symptoms related to the particular compartment. Suppose if they've undergone medial meniscectomy, they should be having medial pain, medial joint pain. And also, there should be some demonstrable cartilage changes in the MRI. So, and that has to be a grade 1 or a grade 2, like outer bridge classification, if you have to consider. So there has to be some demonstrable cartilage changes. So that means we can conclude that because of the meniscectomy is undergoing medial compartment increased peak pressure, and that is giving him the symptoms. So those are all the ideal candidates. And coming to the alignment and the ligament instability, yes, the alignment should be reasonably good, or if I can say correctable alignment. If you can do an osteotomy and if you can correct the alignment, yes, they are still the ideal candidates to do the meniscus transplant if you can correct the alignment. An extreme gross alignment, yes, you cannot do this procedure. And coming to the ligament stability, again, is the same thing. If you can correct the ligament instability along with the meniscus transplant, yes, they're also ideal candidate for it. And coming to the cartilage damages, if they have damages which is more like a grade 3 or grade 4, and if they are focal, and if you can be able to treat it like either with the oats or with the help of any other cartilage procedures, you can still consider meniscus transplant in them.
Thank you, Raghu, for that elaborate answer. But if I give you a hypothetical situation,
okay,
of all that indications and contraindications that you're talking,
yes,
which is the one most that you would want to choose while you're doing your cartilage transplant, or sorry, meniscal transplant, or you will apply importance more to age?
Sorry, sir, I missed that part. Can you ask once again, please?
Age you will give more importance, or to what you see inside, you will give more importance?
No, age is not the paramount importance, but yes, what we see inside is very important. Yes, was there any demonstrable cartilage damages, or are able to see that increased pressure in that particular compartment? That's more important. If they are physiologically young, if their joint is very good, and if you can give them a native knee and they want to continue with their active lifestyle, yes, they are still a candidate for the procedure.
I like that word, physiologically young.
Yes, sir.
Yeah.
Raghu, I have a practical question for you.
Yes, sir. Please go ahead. Yeah.
The patient has come to you.
Yes, sir.
His discharge summary saying that he
Sure.
underwent subtotal meniscectomy or partial meniscectomy.
Okay. Yes.
You have the MRI images latest. Would you depend on these clinical and radiological, or would you like to have a relook there and then decide whether the patient needs a meniscal transplant?
Relook in the sense you want to perform an orthoscopy and then take a decision whether they are candidate for transplant, is it?
Correct. Exactly. That's what I would.
No, sir, that would be little because see now the science has evolved and we have a definite indications and contraindications set. Guidelines have been set now. So but yes, choosing an ideal patient is important, but there are various ways to do it. Like I said, clinical thing. If they have a good demonstrable symptoms, if they are symptomatic for a couple of months or years and a failed conservative treatment after this. So yes, and with the demonstrable imaging changes, yes, we can go ahead with the transplant. But provided there is a good detailed counseling between you and the patient, because this meniscus transplant is the new kid in the block, and not many people are aware of about the consequences of it, how it's going to take, what are the results of it, what are the pros and cons of it, meniscus punch. And so they should be knowing in detail, straight punch, in detail, what are they, if they're decided to go ahead to the surgery, what they're heading to, they should be fully aware of it. Yeah, if we can do it, and I think we can go it with the procedure directly rather than doing an orthoscopy and then taking it, because now we may just give a detailed details, the complete details, what's actually going on in the knee. I hope I'm clear.
Yeah, you are clear, of course, but I had my doubts.
Oh,
because
sure, sir.
many times the images do not correspond with what we see inside.
Okay.
And many times the cartilage damage is more seen on having a look inside rather than on the MRI. And maybe a
But if they
partial.
have so much of doubt that whether they have a cartilage there too, either it's a too extensive cartilage damage, or if they don't have any cartilage damage, then I would suggest that they are not ideal candidate at all. Then you better rather wait, or maybe you can look into the orthoscopy and then see. Yeah.
I was just wondering because you are going to order for a very expensive implant.
Yes, yes, exactly, exactly. So
Better
they are not the
details.
ideal candidate. If you have a doubt on their clinical scenario, then yes, they are not ideal candidate. So yes, I'm going to do a MCL pie crusting now to open up the space. So what my technique is, I always prefer to do from outside in with a 16 to 18 gauge needle. And I prefer to come inside the meniscus rim so that it can act like a pie crusting also and get some blood channels into the meniscus remnant. So this same thing can be done from inside also using the same spinal needle. So you have to do a multiple trephination, and you can also use a diamond rasp after this to create the biology. So creating this biology is very important in the meniscus transplant as you're going to reconstruct the whole thing. So once I'm prepared with the bed, then I'll show the graft and then we'll proceed with the root tunnels. All right. Come back into this, come back, and now you give valgus. Swas, now you give valgus. So with me is my team. Dr. Swas is an associate consultant with me, and my fellow Dr. Mandeep Reddy is from Andhra Pradesh, and my scrub nurse, Mr. Govardhan. So yeah, you can see the space is opened up nicely. can see clearly and the roots are visible. Now we can go ahead with the tunnels. But before that, I will show the graft first. Come back. Okay. Can I have the outside in picture, please? Yeah. Can you see this? Can you zoom it a little bit? So for the benefit of delegate, I'd like to tell you how to process it. Suppose when you generally, fresh frozen allograft is the one that is most commonly used. So when you get it from the blood bank with the freezer, you have to take it off. And my suggestion is when the anesthetists start inducing your case, take off your graft and you have to start the thawing process because that will take around 20 minutes to 30 minutes procedure. So you need to take the graft from the ice cubes and put it in a warm saline of 30 degrees and 36 degrees centigrade with a vancomycin in it. So leave it for 15 to 20 minutes. Then slowly the graft will get softened and then you can start the preparation. So this is how the preparation is. So you have to mark the graft beforehand. So P is for the posterior, T is for top, and A is for anterior. Because once the graft...
Raghu.
Yes, sir, please.
If you can lay it on the table next to you, then ask the guy to focus on it.
Yes.
It will be easy for you to explain.
Yeah, can
because
please.
you will have a lot of clutter behind what you're telling. Yeah.
Can you see now, sir, clearly?
Better.
Yes. So this is our medial meniscus. We were fortunate enough to get a very nice meniscus graft. So this is the posterior part. So we have marked P, if you can see that. And this is the T for top. Because once the meniscus slips inside, you'll get confused because sometimes the graft may get twisted. So then you'll have a confusion. So these markings will clear that confusion. So P is for posterior, T is for top, and A is for anterior. So generally, this is an all soft tissue plug. Instead of the bone plug, we have prepared this soft tissue plug. So if you can see, we have prepared this posterior root with the fiber tape. That it can go with any pattern of stitches like a Chinese strap or bundle stitch. I generally go with the way that I prepare my hamstrings graft. So this is a crisscross stitch with the fiber tape, and you have to make sure that both ends of the fiber tape exits from the inferior surface of the plug. That's important. It shouldn't be exiting from the superior surface. So that this can take this plug into the tunnel. And there's one more fiber stitch at the junction of the posterior third and the middle third. This is important because when you're passing the graft, so both this fiber stitch and this posterior stitch will be pulled so that they can go in an anatomical position. If we don't put this stitch, then only the root will go and this part may get stuck outside. So preferably we put this in the pull-out stitches beforehand before passing the graft. And similarly, we have prepared this anterior plug also with a similar crisscross. Can you show me, get the sizer, please? I'll show you the size of this bone, the soft tissue plug. Yeah. So this is coming approximately around 8 mm. Let me check with the 7.5 first. 7.5 is also going, but it's a little tight. But since
your hand is blocking, Raghu.
Yes. Yeah. Can you see me, sir? Can you show now?
Yes.
Can you see now clearly? So
yes.
This is how we are checking the size of the soft tissue plug. So 7.5 is going clearly, but since we are going to use a flip cutter and that comes with either 7 or 8, so I'm going to choose the 8 mm flip cutter for the posterior one. For the anterior one, let me check with the 6. So 6 is little tight. Yeah, 6.5 is good. So preferably our posterior plug, like at least 7 to 10 mm, I would say that should be your plug which will go inside the tunnel on either side.